Good morning. Today we will discuss thyroid, overview of thyroid. I will take another class on thyroid. Some special parts of thyroid which cannot be included today, we will discuss in the next class. Now, before starting my topic today, this is the anatomical diagram of thyroid gland. Can you please, anyone, quickly describe the anatomical location of thyroid? Anyone? Please, where is thyroid gland in human body? Come on. Okay. You are not cannot clearly define. What is the vascular supply of thyroid gland? What is the nerve supply? So, anatomically, thyroid gland is in the anterior part of the neck, in front of the trachea, just below the cricothyroid nodule. The anatomical distribution is, slide to start with. Anatomical part is three part, right lobe, left lobe, and one middle part, that is isthmus. So anterior lobe, below larynx, Adam's apple, structure butterfly shape, two lobes. Blood supply is superior and inferior thyroid arteries, and nerve supply recurrent laryngeal arteries posterior to thyroid. This is a gross description which we will discuss in details in my next class, because this will be a very important, particularly for those who will be pursuing in surgery. So this I will again discuss in more detail, and there are many MCQ questions arises from this particular part. So that we will discuss in details. What is the physiology? Why it is important? It produces thyroid hormone T3, triiodothyronine, and T4 thyroxine. This is also a gross statement because it actually produces T4, and from T4 to T3 conversions done in peripheral tissues. There are another hormone is released from thyroid gland, that is calcitonin. This is secreted from parafollicular C cells. Regulation, this is being controlled by hypothalamic-Pituitary-Thyroid axis, TRH, TSH, then T3, T4. This axis is very important because hypothyroidism is a gross term. There are three parts: primary, secondary, and tertiary hypothyroidism. So, primary hypothyroidism is where the pathology is in the thyroid gland. Secondary is where the pathology in pituitary gland. And tertiary is where it is in the hypothalamus. We will discuss it again on the next class. It regulates metabolism. BMR, what is BMR? Basal metabolic rate. Growth, development, influence protein synthesis, bone growth, CNS development. Bone growth is controlled by thyroid, and one of the important constituents of the bone is calcium. Calcium is metabolized in the body and the calcium homeostasis is maintained by parathormone and calcitonin. One is from thyroid gland and one is from parathyroid gland. Now we are starting to thyroid dysfunction. Those who will pursue in medicine or gynecology or any major subject, thyroid and diabetes will be your bread earner. You have to know these two subjects very well. We know thyroid gland regulates metabolism, growth, development through T3, T4 hormones. There is prevalence of thyroid dysfunction is 5 to 10% of population affected. So 5 to 10%, if we go for 140 crore people, 10% is a huge population. Majority is hypothyroidism a part of it. Now hypothyroidism is their deficiency in T3 or T4 production. What is the basic organic structure of T4? Any idea? Have gone in the physiology or biochemistry? Two tyrosine ring bonded with a ether bond. There are 4 iodine attached with T4, 2 in the inner circle and 2 in the outer circle. Whereas in T3, there is 3 iodine ring. 2 in the inner circle and 1 is in the outer circle. So from T4 to T3, this conversion happens in peripheral, and this process is called deiodination. What are the reasons for deficiency? Autoimmune disorder, most commonly, iodine deficiency and post-ablation or post-surgery. Hyperthyroidism, where excess T3, T4 reactions, again it is autoimmune as is Graves' disease and thyroiditis. What are the manifestations? Any one of you having any thyroid disorder or taking medications for this? Anyone? Good. Hypothyroidism, clinically we see patient complaining of fatigue, weight gain, cold intolerance. What is cold intolerance? Cold intolerance is that someone is having discomfort in this room temperature today. She is feeling very chill or having discomfort. So this is cold intolerance. Dry skin, coarse skin, constipation, bradycardia, hyperlipidemia, and very rarely severe deficiency leads to myxedema. Hyperthyroidism, on the opposite, have weight loss, heat intolerance, palpitations, anxiety, tremors, goiter, and very severe and very rare is thyroid storm. Diagnosis, main criteria. Very commonly we do use the thyroid profile, T3, T4 and TSH. And the interpretations of these individual leads us to diagnosis of hypothyroidism or thyrotoxicosis. There are some variations in these reports which will be discussed again in the next class. So, TSH is the primary screening tool for hypothyroidism. And when we are considering thyrotoxicosis, we will consider T3, T4. Very important, for hypothyroidism, we will consider the TSH level. And for thyrotoxicosis, we will consider the level of T3, T4. There are some thyroid antibodies to determine whether the origin of thyroid dysfunction is due to autoimmune or not. What are the most important antibodies, autoantibodies? One is anti-TPO and another is anti-TH receptor antibody. One for hypothyroidism, Hashimoto's, and another for Graves. Treatment, we have very limited options to treat thyroid dysfunctions. One is thyroid hormone replacement in case of hypothyroidism, and another is anti-thyroid medications, radioactive iodine, and surgery for thyrotoxicosis. There are some special considerations, that is subclinical thyroid dysfunction, some pregnancy and thyroid nodules, thyroid storm and myxedema coma. We will discuss it a bit details, particularly one of the important aspect, other than the subtle clinical features which I have mentioned just before. Many a times a patient comes in the OPD with a swelling in the anterior part of the neck, whether it is thyroid or something else, how we will differentiate clinically? Any idea? Thyroid swelling will move with deglutition. Any other structure which will move with protrusion of the tongue? Thyroglossal cyst. Good. So now thyroid dysfunction is common and often manageable with treatment. Accurate diagnosis treatment can improve symptoms and outcomes. And we have to consider thyroid dysfunction in patients with non-specific symptoms also. Say patient came with a constipation. Constipation is a very non-specific symptom. Or a patient came with an undetermined anemia, retarded growth, otherwise normal, or a parent came with a children who is very poor at nominal mathematics. So these are the different manifestations of thyroid induced growth failure, intelligence failure. We have to differentiate from some chromosomal defect problems with neonatal hypothyroidism. So these are different non-specific symptoms. You have to very clear in your mind, and you have to screen the patient whenever a suspicion is coming in your mind to determine, because most of the time, excepting neonatal hypothyroidism, thyroid replacement may change the course of the patient life. Now coming to specific, this is Graves' disease. Two conditions, Graves and Hashimoto's. Graves is for hyperthyroidism and Hashimoto's for hypothyroidism. Sometimes there may be, you may be see the one patient started with Graves but may convert to Hashimoto's. So from hyperthyroidism may go to hypothyroidism. Again from hypothyroidism may lead to hyperthyroidism, which is rare. So this is very important, because this autoimmune thyroid disorder is a broad spectrum and a big spectrum. When you are seeing the patient is the most important. You may be seeing a patient in a normal, euthyroid state, but the patient is having the problem. So at random, with a suspicion of your mind, you done an autoimmune test and you see anti-ATPO is very high, but the patient is euthyroid. So there are different variations of the clinical spectrum. So you again, if you are clear in your mind, then you can diagnose the case. Pathophysiology, there is THS receptor antibody which stimulate thyroid and leads to increased productions of T4 and thereby T3. Risk factor is family history, the female sex hormone, the patient, other autoimmune diseases, the hypothyroidism symptoms I have already told you, restlessness, tachycardia, sweating, heat intolerance, weight loss. Patients may appear with goiter. Some prominent features, exophthalmos or proptosis. How do you clinically determine a patient is having exophthalmos? Sorry? When you can see both conjunctiva above and below the pupil, then you can suspect the patient is having some proptosis or exophthalmos. So these clinical examinations, please go through it. Now exophthalmos is very rare, but in here also we have one patient regularly following up at OPD with bilateral proptosis. And dermatopathy, this is pre-tibial myxedema, which we will call. Clinically, when we suspect a patient, then we go for again thyroid profile, where we will see TSH is suppressed, grossly suppressed, T3 and T4 is elevated, and to confirm that Graves' disease, we will do thyroid receptor antibody. What is the treatment? First line is methimazole. We will start with low dose, thrice daily methimazole or propyl thiouracil. Propyl thiouracil will be a better choice in case of pregnancy. Radioactive iodine ablation destroys thyroid tissue. Which radioiodine we will use? Iodine 131. Surgery, some rarely we have to go for surgery, partial or full thyroid surgery with replacement therapy. Special considerations of management, ophthalmopathy, that is exophthalmos. Exophthalmos, what happens? There is some fluid accumulates behind the orbit which anteriorly protrude the eyeball. It is not directly related with thyroid management. So we have to go for some other measures. We have to take steroids. We may take care of the eye so that conjunctivitis or external injury doesn't happen. And maybe go for surgery also. The pregnancy, in another situation where we have to meticulously follow up because it directly affects the fetal conditions also. Methimazole is avoided in the first trimester and propyl thiouracil is preferred. Most common cause of hypothyroidism is Hashimoto's. I have just mentioned. Our autoantibodies, that is TPOB, TPO antibody and TG, thyroglobulin antibody, attack thyroid tissue leading to inflammations and damage. Risk factors, family history, female sex, other autoimmune disease association, type 1 diabetes, celiac disease, etc. Clinical features is gradual onset of hypothyroidism symptoms. And there will be goiter, firm, rubbery thyroid. Here we will find elevated TSH. Any question? Do you have any question? Yes. Ask me, not him. Elevated TSH and low T4. Here treatment is levothyroxine, only option. No other options other than replacement. So whenever there is a patient with family history or other autoimmune disease, we will screen the patient for hypothyroidism. Regular TSH checks to add thyroxine dose, and complications is untreated hypothyroidism can lead to cardiovascular and metabolic disease. One thing very important, many times, particularly since there are no other options to treat other than Levothyroxine or Levothyroxine, it is very easy to treat anyone. They think from our drugs seller, I mean pharmaceutical companies, those who are dealing with pharma shop, quacks, any other form of medicines, Unani, homeopathy, Ayurveda, they all treat hypothyroidism. They know the treatment is only one. You diagnose high TSH and give Levothyroxine. It is very easy to treat. But what is the difference between your knowledge and their knowledge? It is selections of the patient, screening for the complication, where it is no one is suspecting but you are suspecting, and how you are treating, how you will treat, what will be the leading, whenever a patient you have diagnosed as hypothyroid, how you will start the treatment, what is the dose of Levothyroxine, how you will adjust. You will see one patient, young patient, came with say TSH 140, which should be less than 5. That same person went to a quack. He start with 150 milligram of thyroid, and that same patient came to you. How will you treat? You will continue with the 150. The patient not yet started the medicine. He came to you to confirm. The problem is that if you see TSH report, 0.3 to 4.2 is the normal range. So this is a very narrow spectrum. So less than 0.3, this will attract again change the hypothalamic-pituitary axis, or if you not maintained within that limit, so TSH will remain high, so hypothyroidism symptoms will persist. So here it is a low dose for above 50 years. You will start 60% of the dose, that is 1.2 microgram per kg body weight per day. The thyroxine remains, half-life is 7 days. So if you give a high dose and that causes aggravations of the cardiac functions, suddenly leads to atrial fibrillations, you cannot revert it immediately. So always start the medicines in a low dose and gradually increase by 12.5 to 25 milligram per day, by microgram per day, or you may start with a standard 30% dose, increase to 50%, then 75%, then full dose. And it will be looked after, should change at least 6 weeks interval, because you start, wait for 6 weeks, do again thyroid test, then you change. You not change in a hurried manner, because critically vulnerable patient may lead to some other cardiac complications. Please keep it in mind. This is a very important why many person doesn't know why they are using in a high dose. We had teachers, renowned endocrinologists, they used to change the dose. Someone gives in winter season they gives higher dose, in summer time they gives lower dose. So there are different variations someone treats on their based on their clinical experience. But clinical experience one can achieve after their significant amount of practice. But when you are starting, you go by the book, how you will maintain. This is a very important. If you have any case in the exam, they will obviously ask you, how will you start? Because it is, they will not start what will you give, because everybody knows the L-toxin. But how you will give, that is the most important thing. Now, thyroid disorders in pregnancy can be tricky. Here are some key points. Here again, gynecologist will refer the patients to you. What will be your suggestion or advice? Hypothyroidism, the risk is miscarriage, preterm labor, neurodevelopment issues in the baby. We know treatment only is levothyroxine. We need to increase the dose sometimes. Monitor TSH every 4 to 6 weeks. Here again, the important is at which level you maintain the TSH level. Wherein we want to maintain the TSH level during treatment between 0.3 to 4.2 mid-level. That is something around 3 to 3.5. For pregnancy, we have to try to maintain less than 3, rather 2.5 to 3, to maintain the conditions of the growth of the baby intact in a normal growth. Because our maternal TRH active hypothalamus-pituitary-thyroid axis play same in the baby also. So if some dysregulations in the management of the maternal TSH level, this may affect the baby TRH axis also. Hypothyroidism, risk is miscarriage, preterm labor, fetal tachycardia. Here I have already mentioned treatment, PTU in first trimester, but at the last stage you can give methimazole. Screening, all pregnant patients have got screened for thyroid, we know. TSH goal, lower TSH range in pregnancy 0.5 to 2.5 in the first trimester, and fetal monitoring in maternal thyroid dysfunction for growth abnormalities. Another important thing is that thyroid cancers. Papillary carcinoma most common, often slow growing, produces cold nodule. Follicular carcinoma 10 to 15%, more aggressive than papillary. Medullary carcinoma 3 to 5% associated with MEN2 syndrome. Anaplastic carcinoma, very rare, aggressive, very poor prognosis. How will you go for diagnosis? Thyroid most commonly appear with lymph node. Thyroid biopsy, nodule, thyroid biopsy, we go for a FNAC and diagnose it as malignancy. Risk factors is radiation exposure, family history, genetic syndrome. Most important is radiation. The incidence of follicular carcinoma in Indian population is largely due to exposure to radiation. Many a time we unnecessarily do CT scan. CT scan is not a preferred choice of diagnosis in case of children. But we do many a time. One CT scan exposure is equivalent to 400 chest X-ray radiation. And this scattered radiation hampers the make genetic mutations of the thyroid gland. Presentation is thyroid nodule, lymphadenopathy, sometimes incidental findings. Diagnosis, ultrasound, FNAC, there is a classifications done. Bethesda 1, 2, 3, 4, 5. 5 goes in favor of more possibility. And surgery is often diagnostic because there is no scope of excision biopsy, there is no scope of biopsy. FNAC, suspicion, surgery, excision biopsy. You do excise the thyroid gland and do the biopsy. And therapeutic also. Surgery is thyroidectomy, lymph node dissection if needed. Radioactive iodine ablations for differentiated thyroid cancer. Very well differentiated, only one small or two small nodule where radioiodine will ablate the cell. Thyroxine suppression post-surgery to reduce recurrence risk and targeted therapy for advanced or metastatic disease. Now, thyroid storm is a medical emergency. What is thyroid storm? This is a rare manifestation of extreme thyrotoxicosis. It may lead to a catastrophe. Immediate goal is to stabilize the patient. Patient has a history of thyrotoxicosis, had an infections or a surgery or extreme heat weather conditions. Patient has having with a extreme tachycardia in a shock stage. Immediately patient was shifted to ICU. In any cases of shock, it has to be done resuscitations of the patient first. So stabilization the patient, management airway breathing circulation, and to reduce the thyroid hormone synthesis and release, we'll start profile thyroidism. Maybe start with levothyroxine or potassium iodide after antithyroid meds. Block peripheral effects, beta blockers to reduce the heart rate. Supportive care, fluid electrolytes, manage dehydrations, hyperthermia, and hydrocortisone. Hydrocortisone is firstly effective to reduce the conversions from T4 to T3. Additional measure, identify and treat the trigger, infection, trauma, etc. and monitor ECG, vitals and thyroid function. Keep it in your note for short note. Thank you.